Welcome everyone to our webinar today. Our webinar is 3 approaches to the ongoing monitoring and evaluation of child and youth mental health services. So my name is Julia Kujava and I'm here today on behalf of the center. I'm also co-facilitating with Crystal.
Hi everyone, my name is Crystal and I'm from Children's Mental Health Ontario.
We'd like to start our webinar with a territory acknowledgement. We recognize the history, strengths, and diversity of Canada's First Nation, Inuit, and Métis communities. We are committed to engaging respectfully with Indigenous children, young people, and families within and across nations in what is known as Ontario. Ottawa is the traditional unceded territory of the Algonquin. A few housekeeping notes for everyone joining today. If you do have any technical difficulties, please feel free to reach out to Tracy. You have her email and you can reach her via chat. We ask that everyone keeps their camera off and your microphones muted unless called upon. We will have an opportunity towards the end of the session for questions, and we encourage you to submit questions throughout the webinar using the chat function. Following the webinar, you'll receive a short link to complete a really quick evaluation, and we just ask that you complete that to enable us to plan future sessions like this.
Thanks, Julia, for the housekeeping and the intro. So we just wanted to start off our webinar today by providing a bit of context around the evaluation study that we did, and also the first part of the webinar that we did earlier last fall. So some of you may already know that early on in the pandemic, we launched with the center an evaluation study to learn about the process that agencies undertook to implement virtual care and looking at the impact that it had on clients and service providers. And the goal was really to just gain insight into what worked well, identify some areas for improvement so that our sector could add virtual care as an option to the range of mental health services that are currently being provided for children and families. And at our webinar last fall, we were able to present the findings of the study, looking at how agencies, service providers, and clients experience that transition to virtual care. So in our presentation, we talked about some of the benefits and the limitations of virtual care. For example, where for some, it really improved access, especially if they were experiencing challenges with finding services nearby or arranging transportation. Virtual care really helped them with their access to mental health services. But then for others, it was actually a barrier because they didn't have access to internet connection or digital devices to be able to use that virtual care option. We also looked at some of the facilitators and challenges to implementing virtual care. And this included having supportive leadership. We found that, and also ongoing training to staff really allowed the entire team to be able to provide virtual care effectively, and also engaging staff and clients throughout the process of developing policies and processes and solving problems just along the way. But yeah, so throughout our survey, our study, we found that a lot of agencies really were just learning as they went and are really still learning right now just to see how best to offer virtual care as an option based on the type of services that they have and the populations that they serve. But we did hear from many of those who participated in the survey that they wanted to continue providing virtual care as an option on an ongoing basis. So we're very excited for part 2 today, where we'll have an opportunity to hear from some of these agencies on their journey so far and what they plan to do in the near future.
Okay, so I'm just going to welcome and provide some brief introductions to our presenters. So we have a number of presenters here today. Natasha McBurdy, she has over 20 years of experience in community mental health and is the Associate Executive Director at Crossroads Children's Mental Health Center. She's a founding member and co-chair of Counseling Connect and works with client partners and children in child and youth mental health agencies to contribute to developing knowledge around infant, child, and family mental health. She's also a mother of 3 to creative and spirited children. She's here today with Dr. Maria Rogers. Dr. Maria Rogers is an associate professor in the School of Psychology at the University of Ottawa. She completed her degree at the University of Toronto and completed her postdoctoral fellowship at Sick Kids. She has broad interests in social, emotional, and academic development of youth with executive functioning difficulties, and is particularly interested in how parents and teachers interact with high-risk children and youth. We also have Kelly Fithian here today. She is the Manager of Research and Evaluation at Kinner Child and Family Services, where she leads a team with a mandate to support evidence-informed decision-making. The department is responsible for evaluating client, family, and staff engagement and outcomes, and right now they're focused on virtual service delivery, remote work, and reopening of in-person services. Daniel Kiakia is here as well. He holds a master's degree in social and personality psychology from York University and is a research advisor at Kinner Child and Family Services. He will be on hand for any questions in regards to Kinner's evaluation. Last but not least, we have Mark Fraser, the Director of Clinical and Client Services at Compass. He's a registered psychotherapist and has over 19 years of clinical and research experience, working with complex children, youth, and families within child mental health and child welfare. So without further ado, I'm going to pass it to our first presenters, Natasha and Maria.
Thank you, Julia, and thank you for the opportunity to share a little bit on this project with you. So I'll just go right into the next slide, please. So for today, we'd like to give you an overview of some of the work that we've been doing together to evaluate the implementation of online group-based mental health and addiction services for youth and caregivers. And we're not so much focused on the results of our evaluation today because it's still in progress, but we really want to share our process with you so far. So just to give you a sense of how this all came together, so like much of this work, the impetus for delivering mental health and addictions groups online was precipitated by COVID-19. And as we were transitioning our services to virtual, we scoured the literature as quickly as we could to try to find some best practices to guide our work. But there really wasn't much when it came to virtual mental health and addictions groups for children and youth. So given the need to get services out the door, we decided right off the bat that we would just need to implement and evaluate later. And so definitely wanting to better understand the impact of our interventions, we were able to apply for a grant through FRAME. It's a grant called the Virtual Innovations in Care. And we were able to bring together a group of partners to evaluate the process of online group implementation to better understand, what worked and what didn't, as we were suddenly and rapidly adapting our practices to the virtual environment. Next slide, please. So I would say that one of the strongest features of this initiative is the partnership element. So very early on in the pandemic, a group of us came together to focus on groups specifically. And to our advantage, Crossroads was already engaged in a really strong research partnership with the University of Ottawa. So they were on board. And then because we saw incredible opportunities for the delivery of mental health groups online, a subset of organizations who are working as part of a collaborative called Kids Come First in the Ontario Eastern region came together to see how we could collaborate to augment the group service or the group offerings. And part of what was driving our collaboration were some ideas that, we could really augment this service in ways like rather than being limited by the expertise or resources of one organization, now in the virtual world, we could conceivably collaborate across a region without being limited by things like geography or the size of the space. We could also augment anyone's organization's capacity by co-delivering groups, by staggering, when groups started, for example, so that people wouldn't have to wait as long to get into a group, or, of particular importance to our rural partners, if there wasn't enough people in a particular region, they could participate in groups, in our case in Ottawa. So there were lots of opportunities that were opening themselves up when we thought of, online virtual groups and the possibilities of interagency referrals. So to get back to this specific project, we have an established advisory group who meets bi-weekly, and it consists of 10 agencies. You can see the logos on this slide. They span mental health, addictions, from birth all the way till, actually some are also serving adults and have a lifespan focus. We also have on our advisory committee representation from Parents Lifeline, which is a network of family members who with lived experience who support other family members who are navigating the mental health system. And we have 4 paid youth advisors that we were able to recruit through our partners. So we all meet together to co-develop the evaluation framework. We've worked together to develop and refine the tools. We're now meeting together to analyze results, and lots of ideas about knowledge mobilization products that we have launched and are looking to launch as a result of our work together. So we've also done some consultations more specifically with youth to get a better sense of what they're curious about learning about online mental health groups. And then finally, as mentioned, the advisory also includes 3 researchers from the University of Ottawa and their students who are research assistants. And this has really been instrumental in informing the project. And before I go on with that, I'll let Maria speak a little bit more to that piece as she presents on our research and research methods.
All right, that's great. Thanks, Natasha, and thank you for inviting us today. Yeah, so we decided to take a mixed method approach to this project. So we have both a quantitative aspect as well as a qualitative, where we're able to dig a little bit deeper into with clinical interviews or individual interviews. So we had we've administered a survey, which consisted of 20 questions, as well as 20 multiple choice questions, as well as some open-ended questions. And we did an online survey. At present, we have about, I think about 90 responses to that. If we could move on to the next slide so I can, right. Right, so our goals were to really look at both how virtual groups compare to in-person, as well as just to get a sense of practitioners' experiences with regards to the challenges and advantages of administering groups this way. So as I mentioned, we have survey data on about 90 practitioners, and we're currently in the process of interviewing about 20 of them with more in-depth qualitative interviews. And those are really intended to get at both the administrative and logistical processes involved, so sort of the more of the practical implementation side of things, as well as sort of what's working for the clients, what are some of the barriers and gaps, what are the key lessons learned. So if we could go on to the next slide here. So this really is, as Natasha mentioned, this is really hot off the presses. We have just, our survey concluded on March 1st. And it looks like from the survey data, we have the majority of respondents were group practitioners involved in mental health and addiction treatment groups. About a quarter were psychoeducational or skills training groups, and then about 14% were support groups. And to the next slide, please. Okay. So right now, at present, we don't have, we have a lot more analysis to do with these data. We're not able to present on the interview data yet because that is happening currently. But our questions, as I mentioned, our questions for the survey really, there were sort of 2 sections to the survey. One is, how satisfied are you with these different aspects of virtual groups? And then secondly, how does this compare, in your opinion, to doing groups in person? So we wanted to sort of get a sense of both of those elements. And many of the questions were probably similar to some questions that you're all asking around, you know, attendance, adherence, motivation, and stuff like that. We also asked questions that were more specific to groups. So things like getting a sense of the group facilitators' concerns about privacy for individual members in the context of a virtual group, tracking individual client progress within the group setting, how does the working alliance between different members of the group work when we're online? So some things, of course, would relate to sort of more individual virtual care, and then some more specific to group work. And so we don't have the quantitative data analyzed in terms of from the survey questions, but what we did ask was three open-ended questions at the end of the survey. And that was around participants' perceptions of the advantages of group work online, the challenges that they see, and to this point, any sort of key lessons learned. So we've just pulled here a few things that came up in the open-ended questions. As many of you are familiar with, some of the advantages that we're seeing is increased attendance. So I think that goes for both group and individual work. So we're more able to get participants online or clients online. Many of the respondents reported that they were hearing from their clients that it was easier because there was fewer concerns around childcare, scheduling, transportation. And interestingly, there was some comments that those who might normally not feel comfortable in a physical group setting felt more comfortable in the online group setting. So something maybe unique to the online group setting. With regards to challenges, again, similar to what we sometimes see in in-person groups, ensuring equal participation among group members, but maybe it presents different challenges when we're doing these groups online. Of course, again, not specific to group work, but poor connections, inadequate bandwidth, and that sort of thing presenting as a challenge, as well as clients' ability to maintain privacy. And so again, doing group work, doing any sort of therapy work in the online world, it raises a new set of concerns around privacy. Some of the lessons learned that the practitioners shared with us were around kind of the importance of taking that extra time to build rapport in the online environment because it's between group members, because there's some challenges there. Some comments about difficulties maintaining boundaries in virtual care, as well as kind of being comfortable and knowledgeable about technology. I think we all know that probably most of the youth we work with are far more technologically advanced than many of us. And so being sort of up to speed on what's, on the technology and the features about the virtual space that can allow for more engagement in groups. So things like breakout rooms, things like Kahoots, like things that practitioners mentioned that, were specifically useful for the group setting. And yeah, so this is, before I turn it back over to Natasha, I'll just say this really is a work in progress. We're still really excited to look at these data. And we'd also be happy to share our survey with anyone who's interested. We took it from some existing literature, modified it, consulted with the advisory group. And also we really look forward to sharing the results from the interviews when we get to that point.
Thanks so much, Maria. I feel like those, first findings are just such a teaser, and I'm really looking forward to hearing more about the interviews as we get into those, because I think there's so much rich information that's coming out of these interviews with service providers. So what I would flag in terms of next step is what's really exciting is that because the evaluation has been co-developed by the university, the agencies, and youth and families, the results are likely going to be very practical and usable. And we know that children and youth mental health agencies are craving guidelines. I know we are. And because they've been involved in the research design, as I mentioned, it really, I think, puts in a check to make sure that we're asking the right questions and that we're gathering information that's really going to help guide practice moving forward to improve outcomes. And then we also know from working with youth and family advisors that there's a need to help those seeking services to better understand what the value of virtual care is, specifically what works for who, and what they can expect from virtual services, things like the risks, the benefits, and all that kind of thing. And finally, building on the research, we're poised now to look at the service experience of those participating in the groups, which is what we're focusing on next. So our goal is, rather than just adding virtual as another service option that's available to clients, we really want to drill down and better understand which modality, be it in-person, virtual, or a combination of both, is going to work for who and under which conditions. So stay tuned, because hopefully we'll have a lot more to share about this as we move forward. But we appreciate the opportunity to come present to this group. And if you have any feedback, or if you have questions about the survey or interviews, as Maria mentioned, please feel free to reach out to us. Thank you.
Thanks, Natasha and Maria. It's really interesting to see Some of the pieces that you presented are quite similar to our findings that when we conducted virtual care evaluation in the summer as well. So we're excited to see what else comes from that. So now I'm going to pass it over to Kelly to present around child and youth mental health virtual services at Kinark.
Thank you. First, I just want to thank everyone for joining us today and for giving us an opportunity to share some of the results of our evaluation of virtual services. We'll be focusing specifically on client and caregiver experience, as well as some preliminary clinical outcomes of virtual treatment during the pandemic. I'd also like to acknowledge Dan Kiakia, who's here today, who's led this evaluation and is here to answer any questions that you might have. So move to the next slide. Sorry, bear with me. There we go. So as you know, mental health among children and their parents has deteriorated during and because of the pandemic, and we've had to adapt to the pandemic and to our clients' needs by offering virtual service options. We also need to pay attention to our staff and how virtual service delivery might present challenges for them and address those challenges through evidence-based solutions. So as part of our evaluation plan, then we are looking at three broad areas. First, client and caregiver experience, such as comfort with virtual services, perceived effectiveness of virtual services. Two, we're looking at treatment outcomes after participating in virtual services. And three, staff experience. So starting with, if you could just go back to the methodology. Perfect, thank you. So starting with the client and caregiver experience, clients and caregivers experience was assessed using telephone surveys of clients who had received at least 2 virtual treatment sessions. We looked at general comfort levels with virtual services and comfort with the privacy of their sessions. I think you'll see that the results are very similar to what Natasha and Maria have reported. We looked at perceived effectiveness based on OPOC items that we've used in the past. And we looked at preference for virtual versus in-person services moving forward. We also asked about audio and video quality, and that was really about being able to respond to client staff needs as we were launching our virtual services. Go to the next slide. Perfect, thank you. So with respect to the virtual survey, we've been collecting data since August 2020, and this is in an ongoing way. Our central intake staff contact all clients and caregivers, like I said, who have received at least 2 virtual sessions. And since that time, we've received feedback from 75 youth and 243 caregivers. And where possible, we have been comparing our results to client experience data that we've collected last year. So this would be OPOC data that is specifically to in-person services. And so here we have data from 67 youth and 200 caregivers. Thank you. So starting with comfort with virtual services, if we could just sort of focus on the graph here on the left, the orange bars are the children and youth, the blue bars represent caregivers, and along the x-axis or the horizontal axis, you see 2 items. On the left is comfort with virtual services, and the right is comfort with the privacy of their sessions. And the y-axis represents those who report being very comfortable with each of these items. So what we can see here is that both caregivers and youth were largely comfortable with virtual services and were comfortable with the privacy of the call. But among those who expressed discomfort, which we can see about a third, expressed just a general preference for in-person services, including the belief that in-person treatment is actually more beneficial. We also saw some general concerns about the privacy of the call and distractions that are happening during their session. Caregivers of young children often reported that virtual services just weren't working for their child because they were too easily distracted. They couldn't focus on the session. And in some cases, there were clients who they couldn't be alone in a room, so they weren't able to have the private sessions with their therapist that they were hoping for. And on the next slide, we're looking at perceived effectiveness of virtual services. You can see 2 graphs here. On the left, we see youth, and on the right, caregivers. In-person services are represented by the purple bars, and the green bars are virtual services. And the numbers represent the percent of respondents who agree or strongly agree with each of the items along the y-axis. So sorry, the x-axis. So here we can see our results suggest that overall youth appear to respond similarly to virtual treatment relative to those who received in-person services in 2019. Regardless of whether they received in-person or virtual, we see that clients largely agreed that services helped them deal with their life's challenges, that their services were high quality, and that they would recommend these services to a friend in a similar situation. Among caregivers, results were also comparable for virtual and in-person. However, we do see a bit of a gap, a small gap, and perhaps a notable one in terms of the percent who agreed that the services were of high quality. We also asked respondents to provide some open-ended feedback about their experience with virtual services. And on the one hand, for some children and youth, we heard that it was difficult to focus on virtual treatment, to sit in front of the computer for a long period of time, or practice their homework, such as exposure therapy, and to develop a rapport with their therapist. For others, though, we heard that they were more comfortable at home, they were better able to attend sessions on bad days or even at all, and that they were more accepting of services when they were delivered virtually. Some of the other benefits of virtual services that we heard included things like, convenience, not having to drive or rush from work to sessions, and then not having to worry about childcare, and that both parents could attend the sessions, which was beneficial for them. And lastly, we asked clients and caregivers about their service preference moving forward after the pandemic. So here you see the percent of respondents who agreed who said that they would want all virtual, all in person, or some mix of virtual and in-person services. And I think one of the big takeaways, well, there's two big takeaways here, that we see substantial numbers of clients who are wanting some sort of virtual services after the pandemic. A small but not insignificant proportion would like strictly virtual services, but a substantial number would also like strictly in-person services moving forward. Okay, thank you. Yes, okay, so we can move to the next slide. And moving on to treatment outcomes then. So here we made use of Inter-CYMH data that we collect at admission to treatment and again at discharge from service. We compared clients who received all virtual services to those who received all in-person services, focusing specifically on scales that are part of the Inter-CYMH, so things like depression, anxiety, aggressive behavior, and so on. Since the pandemic and our move to virtual services, we have data, admission and discharge data for 30 clients, and we compared their results to those who received in-person services in 2019, and our sample size there is 101. So we do have a pretty small sample for the virtual group. This is because we included clients who received only virtual services. Obviously, there are a considerable number who would have started receiving in-person and then shifted to virtual after the pandemic. But we wanted to keep this analysis really clean, so we excluded those kids. But that said, we do plan to analyze their data in the future. Because of the small sample size, though, we should consider these findings preliminary. We didn't have a sufficient sample size to control for things like age, which I think is interesting and potentially useful, because we might find, for example, that older clients respond better to virtual services than younger clients, or we might find that older clients presenting with certain symptoms fare better than younger clients presenting with similar symptoms, or vice versa. So starting with our clinical externalizing scales, I'm just going to sort of explain what you're looking at before diving into the results. Along the vertical axis or the y-axis, this is the standardized difference from pre to post. So this is the change in scores on the Inter-CYMH scales from the start of treatment to the time of discharge. Purple bars represent those who received in-person services, and the green bars represent those who received virtual services. And the asterisk above each bar tells us whether the change from pre to post was statistically significant. So just by way of example then, to interpret this, we can see that on the aggressive behavior scale, aggressive behavior improved on average by 0.82 among those who received in-person services and 0.83 for those who received virtual services. For both groups, the change was statistically significant. So both groups experienced essentially the same amount of change from pre to post on average. These values also represent effect sizes, and that's the magnitude of the change from pre to post. So just looking at the box in the top right corner, you can see that a change from pre to post of 0.8 or higher would be considered a large improvement. A 0.5 would be a moderate improvement, and a 0.2 would be about a small improvement. So our analysis suggests then that clients who present with symptoms of aggression and on risk of harm to others experienced comparable gains. It appears that virtual and in-person services benefit both groups equally. We don't see the asterisk for the risk of harm to others. The sample size there was very low, but the effect size suggests that there is a meaningful change there. When looking at distractibility, I don't think these findings are surprising. We see substantial improvements for kids who received in-person services, but only small and not significant effects for those who received virtual. We know that these clients are difficult to engage virtually, and the feedback we've received from caregivers support this. Some of the open-ended feedback we've received, for example, suggests that, a lot of caregivers, they want virtual services moving forward, but they want it for them, and they want their kids to be in-person services because they just aren't able to engage in the same way when that service is provided virtually. When looking at disruptive behavior, on the other hand, we can see both groups improved, but the effect size appears to be larger for virtual. So virtual services appear to produce greater reductions in scale scores. One hypothesis we had is that families of children presenting with disruptive behavior tend to have a lot going on, and the option of virtual services just might allow them to attend sessions more consistently. We would really love to hear your thoughts on some of these findings. Some of them really had us scratching our heads, and so it would be great to get your feedback and ideas, and so please feel free to put them in the chat. Moving to our clinical internalizing scales, we can see that clients presenting with symptoms of anhedonia and depression responded quite well to virtual and in-person treatment. There wasn't much of a difference between the two groups. The anxiety result was surprising. We see much larger improvements for the in-person group, even though evidence suggests that anxiety lends itself well to virtual treatment. That being said, the average score at pre among our virtual group was pretty low. This isn't intuitive given what we've heard about anxiety levels among children and youth during the pandemic. So there wasn't a lot of room for improvement, just given how low it was when they started. But it might be that anxiety is presenting behaviorally and our anxiety scale isn't picking up the anxiety that kids are experiencing. The small effect size might also be partly because anxiety has been difficult to treat during COVID. If the anxiety is due to COVID, it might be resistant to change, or if it's social or school related, their ability to practice exposure is probably pretty limited. And looking at self-harm, these results appear to suggest that virtual services are more effective than in-person. One hypothesis is that clients may not be experiencing the same social pressures during COVID, so they aren't self-harming. This suggests the improvement that we're seeing in virtual then from pre to post isn't necessarily entirely because of treatment, but a byproduct of the pandemic itself. But again, we would really like to hear your hypotheses on this one. And just very quickly looking at global symptoms, I don't think there are any surprises here. We didn't see a big difference between virtual and in-person in terms of improvements on caregiver distress and family functioning. Improvements on peer relationships were much larger when the services were delivered in person, and in school disruption saw much greater improvements when services were provided virtually. These findings might also be tied up with COVID. For example, we know that social issues tend to drive school disruption. So when these kids are removed from the classroom, they might fare better. So just broadly then, in terms of our key takeaways, I think there's some really great news here. We've heard a substantial proportion of clients and caregivers, they feel comfortable receiving virtual services. They see it to be effective for themselves and their families. They prefer to receive, and they are expressing a preference, at least in some form, of a mixture of in-person and virtual services in the future. So there is a desire for virtual services to stay, at least among a large proportion of clients and families. We're also seeing moderate to large clinical improvements on our externalizing, internalizing, and global symptoms for those who are participating in virtual services. And those improvements were often comparable to those who participated in in-person services in the past. So just very quickly to talk about next steps, we plan to continue looking at treatment outcomes, including the perceptions of outcomes among clients and caregivers after they've been discharged from services. We want to look at our session by session target tracking. Here, clinicians set goals with their clients and monitor progress towards those goals at each session. We'll continue to analyze our inter-eye data so that we can build up our sample size. And we're going to be developing clinical profiles to determine whether some clients are better suited to virtual services or than others, depending on their symptomatology and demographic characteristics. When COVID passes, we, along with many other service providers, will continue to offer virtual services. So when that time comes, we'll need some sort of objective evidence-based criteria to inform those decisions about which clients are well suited to virtual and who would benefit more from in-person or some combination of virtual and in-person. So thank you, and I'll turn it back to Julia.
All right, thanks, Kelly. I think lots of really interesting pieces that have come out from your research so far, particularly that piece you pointed out around self-harm. So looking forward to digging into that a bit more. For now, I'll pass it over to Mark Fraser to tell us a little bit about the evaluation of virtual care services at Compass.
Thank you so much. Again, a big thank you to Purnima and team at the Center of Excellence for their great work and for bringing us here today. This presentation is from my perspective as a clinical director. So it's very high level, very general approach, and I just want to commend the last two presentations. Phenomenal job, everyone. For today, I want to perhaps embed perhaps this discussion in the background of who we are as Compass and perhaps situate us in the province on where we are and the populations we serve. I'd like to also share perhaps the strain in which we arrived to our virtual solution, spend a few minutes there, and then dive into the snapshot of how we implemented virtual sessions from a service perspective, clinical director perspective. Also, how we then developed our mixed method approach and trying to understand really how our service delivery was impacted and affected the way we address the needs of children, youth, and families within our catchment area. I will also bring the staff voice into this as well and discuss some of the challenges and barriers in trying to collect this information. And of course, I'll end with some key takeaways or messages. Oh, wow, you guys are fast. So Compass is a child and youth mental health agency. It became a community-based agency after moving away from the hospital in 1991. We became a lead agency in 2004. And our catchment area is approximately 44,500 square kilometers. It's almost as big as France, right? We have 5 sites, 2 in Sudbury, but then we have Espanola, Little Current, and Chapleau. So to give you an idea on how big our catchment area, from Sudbury to Chapleau, it's approximately 5 hours, right? So a really huge area to deliver our core services. We have 5 school boards, approximately 38,000 children and youth under the age of 18. We have 3 core service delivery partners, ourselves, of course, the hospital, and an Indigenous agency, Nojmateg, and they are based on Manitoulin Island and in Espanola. We are a multi-service agency, so we offer child and youth mental health services, of course, as well as child and youth developmental services, resource worker service. So these are early years. We go into daycares to look for developmental issues. We also have the supervised access program, the ISSP, and of course, Section 34s, which are mandated forensic psychological psychological assessments requested by the court. These are some of the outcomes at any given time, right? We deliver about 12,000 client sessions, over 4,000 counseling and therapy sessions, right? So we do a really great job at understanding our everyday business. But the challenge in these times is not every day is the same. Every day is different. So we really needed to develop ways to capture information that were outside of BI solutions and ticky boxes and EMHware, which is our client information system. We really needed to develop something that gave us some information regarding how our services were landing and were aligning with the needs of children, youth, and families. Understanding that children and youth and their families, that moms and dads now are working from their homes. I have 4 kids myself, right? I have a parenting partner, right? My wife is an educator, so she's gone. And in Sudbury, there was a time where I was it, right? I had to run a business and try and feed 4 hungry kids. And I know I'm certainly not alone here, but that's our reality today. So this here was just to show that we have we do a really great job at capturing the information of our everyday business. But these COVID times really challenged our nimbleness in trying to develop systems that capture the voice of clients, of children, youth, families, and of course staff. When we found ourselves at the point of moving to a virtual service, right? My simpleton brain went, oh, well, we have Skype, right? We have FaceTime. That's good. Everybody has FaceTime, and that's not a problem. And that didn't land well with our IT department. There were many different things to consider. And we did our homework here as well. So we identified some promising virtual solutions, and then we had a criteria, and we ensured that these criteria were met, and we landed on the Zoom Health version. And we adapted the Zoom Health version, not really knowing what the Zoom Health version was. And it was during the time when people were Zoom bombing. So we had many of our stakeholders saying, Mark, you just onboarded something that is in the news and there's some significant risks. But it wasn't until we fully understood what we were getting into with Zoom Health version, right, that we were comfortable in selecting that solution. We also have a teleworker phone system. And basically what it is when we're in the office, we have a telephone, we were able to pick it up and just plug it into our interweb at home, or internet at home. Next slide, please. So this here offers you a snapshot and gives you, I guess, some understanding of how quickly we onboarded our virtual platform. So you'll see that in the first bar, right, there's no gray, and that's because we weren't virtual. And you'll see over as the weeks progress, right, the gray expands. So that means our onboarding of the virtual sessions was gradual and never reached beyond the 50-ish% mark, right? And you'll see that around June, we had returned to face-to-face, and as the gradual face-to-face increased, our use of video decreased, but the blue represents telephone. And to me, that was interesting because telephone still persists, right? Whether it's more video, less in person, or less in person, more video, telephone seemed to be, until the November, right, seemed to be consistent-ish. Not a technical term, definitely not a research term, nor a scientific term. I use it a lot. But when we did move back to virtual services, right, you'll see that phone and for the 2 weeks at Christmas, where Doug Ford made the announcements of the lockdown, you can see us moving back to virtual services, and then telephone was also increasing their usage. Next slide. So a few words before I proceed. We're no experts in evaluation. What we're sharing are some of our approaches to trying to understand what we are currently doing, right, and what we need to do next, right? This is purely an evidence-informed decision-making process, right? And we need information, especially during these unpredictable times, in order to make our next decision and to understand what we need to do next. And as a clinical director, what we are doing and what we need to do next is incredibly important for me, especially during these unpredictable times. So there's caveats to what I'll be presenting here today. Collecting this information has been very difficult for us, right? Especially the qualitative pieces, because of the voluntary nature in which we collect this information. So we have very small sample sizes, and to be transparent, a lot of the people that were asking the questions are survey fatigued, right? So where some clients after their sessions, they said, look, I don't have time to complete a survey. I just need to jet. I need to feed my kids. The dog needs to go out. I'm done with Zooming, right? So they tend to go to other things. Small samples, what comes with small samples are limitations to the interpretation. And mixed methods involves qualitative and quantitative. It involves many different groups. But here I'll show you how we use the information that we already had with the information that formatively, right? We landed on some questions, and we're continuously developing these questions to be even better. So focus here is on possible methodologies, and we're not good at it yet. I'm not an expert like my other colleagues are, nor do we have, we have some expertise within our agency, but to say that we're the ultimate expert, especially with qualitative information, it's a moving target at the best of times. Next slide. So these are just slides of all the information that we are currently, right? So this is something we do right. We always look at historical, 3-year historical averages to current state, right? So that we have a reference, and for all intents and purposes, right? Whether it's COVID, pre-COVID, or COVID, we maintain our historical averages, right? So we thought that this COVID would have an impact to our services, and as this data shows, right, not so much. So we're missing something, right? Our suspicions. So what we had to do was focus on number 2, and that's to add to the current data e-survey results, but really taking a qualitative approach and asking open-ended questions in order to collect the voices of the clients, the children, youth, and families we serve, as well as staff and their experience during these virtual times. Next slide. So what we found, right, when we looked at the age groups, the 12 and over versus the under 12, because of the small sample size, I wasn't able to test for significance here, but we see within the video conference, right, they're slightly lower. I wouldn't suspect that these are significant, but definitely there's slightly lower ratings on the perceptions on the process of today's session was efficient. I felt welcome from the start, and I was satisfied with the use of technology, right? So those are some preliminary findings. Again, the power of this analysis isn't where we would like it to be because of how difficult it is to try and collect this information. Next slide. What we did find, right, when we looked at our direct service hours, there were impacts to our direct service hours. And for us, we were wanting to understand that piece, and I'll share some information that staff shared. But we also found that in 76% of the sample we did have, which was upwards to 120, 130, well, here it's 33. As of December, we found that 76%, right, most people want in person. And when it's available, you'll see that when it's available, there's that gradual increase of face-to-face service. So for us, that's an interesting one, and we continue to offer face-to-face service with all the IPAC and PPE. But you'll see that even though they want in-person services, that our virtual delivery has very high satisfaction rates. Next slide. So what the clients have said in the qualitative piece is they really like, we at the agency made certain that when people call, you can reach a real person, and that came out in our qualitative survey. So they like real people, real persons answering the phone. It speaks to a warm welcome, a warm voice. They like options, so people like options, right? And video is one of them, as well as telephone or coming in for in the office for a session. They like that. Have a plan B, they like, right? So for us, if we were going to move to video, right, we had a plan B for phone, so we made sure that the plan B was known to clients. And for us, we made sure that when, especially with our brief service, that when people called our brief service, that we were quick to respond. And people, time and time again, were surprised on how quickly we were responding to their brief service, right? So for us, we wanted to try as closely as possible, mimic the walk-in, immediate access to our service, and this provided some information that we are on the right track. Next slide. Some of the challenges, some of the older youth indicated that they feel self-conscious seeing themselves on the screen, right? They also spoke to confidentiality, so it seems to align with some of the findings that my other colleagues found, right? So one said, it seems too open. Like, I can't see where you're at or if anybody behind here is listening to my story. So confidentiality for them was really important. Some of them indicated that it's hard to see what the clinician means when they can't see their face over the telephone, or when things are cutting out or the bandwidth is too slow. It's really hard to follow some of the conversation, the back and forth that a therapy session has. And they too indicated that some sessions were hard to focus, especially during when you're in busy households, and of course the home environment could be filled with distractions. Next slide. The staff voice, what we did well, the staff enjoy Zoom in the ease in which we can close the informational black hole. So we made it a point that we increased our all staffs so that we could provide information in a quick way, and that these meetings were systematically using technology in order to connect people. We also made sure that as a leadership team, we recognize that these are challenging times in delivering the service, impacting the possible direct service time. Our staff enjoy and find it very important to have regular updates and check-ins with managers and supervisors. So Zoom allows you, right, no matter where you are, right, Zoom allows you to have really good check-ins with managers and supervisors, and also the speed in which staff really appreciated the speed in which we moved to a virtual platform and how easy it was to use the Zoom. And of course, empathy during these unprecedented times is also a strength. And the last slide here, the second last slide. So although the staff found communication was, hey, you guys are doing a great job, they also found communication as a gap, right? So consistency in messaging, sometimes communicating too quickly, not communicating enough, the accuracy and the lack of transparency. What happens is COVID times, sometimes you had to pivot really quickly, especially when announcements of schools and announcements of the province. So for us, it was important for us to ensure that our decisions were based on bigger decisions across the province. The other piece is, at first, when our service disrupted, we were delivering no services because it was almost a freeze response. We didn't have the virtual platform in which to deliver services. So our direct service hours, we were monitoring direct service hours to ensure that we were gradually working towards our benchmarks. And what staff indicated was, during really difficult times, you want to focus on quality and not so much on quantity. Quantity is still important, but we may want to focus on quality more than that, because there are some many challenges in delivering services, especially when you're in the home setting. People miss the social connectivity, and I think other research has suggested that. Zoom fatigue, and the other piece regarding staff's voice is the number of meetings. So the booking of clinical sessions back to back to back can really exhaust a clinician, and to put team meetings and all staffs and other community-based meetings, number of meetings equate to the Zoom fatigue. So the takeaway, the key takeaways here are clients want face-to-face. Staff like technology and its ability to close the informational black holes, but they still miss the in-person social connection and interaction with their teams. Mixed methods are best at evaluating how technology is working for clients and staff. However, designing these and interpreting these is truly complex, because trying to get to the data is hard, especially when it's volunteer and people are really tired. Our take-home message was direct service is going to be disrupted, and for us, it's to ensure that we structure our day to ensure that quality of service is of utmost importance, because there's many variables at play that affect direct service. Clinical supervision, staff said, indicated that this is super important when you're trying to deliver the best service, and I've already spoken to point number 6, that in these truly challenging times, quality is super important. Thank you.
Great, thank you, Mark, and to all of our presenters. I liked the point around just remembering that we're not experts, but we're all learning together, and hope that this webinar has supported that as well. So we're going to move into our question and answer period, and we'll moderate some of the questions that came in. So one, which was, I think, directed broadly at presenters, was just in terms of response rates for client surveys or engaging clients, and if there were any specific strategies that you had used. So I know we had heard that it was hard to engage clients currently over virtual means. So any of the presenters are welcome to take a stab at responding to that question.
This is Kelly. We had similar experience when trying to get feedback from clients after sessions. We had initially tried to engage therapists to complete surveys with their client at the end of the session, and they just weren't into it, to be honest. Like clients, they had just spent 45 minutes to an hour with their therapist. They didn't want to be on the call any longer. So we actually engaged our central intake staff to make phone calls and do the surveys over the phone. We're fortunate to be able to have the resources to do that. So basically we pestered them, right? We called once, we called twice, we left messages, and we were able to successfully get responses that way.
From my perspective, I think this is something that myself and my management team have really thought long and hard about. And for me, I think a potential target is the service agreement. If you built it in as one of the requirements that part of our service agreement, of our service delivery, is feedback, right? To further inform how well we're doing and where we need to go next. If we built it within the service agreement or the knowledgeable consent process, right? And we have different sections to that, but if one of those sections can talk about, your feedback is critical in our success, and if you built it in and make it as a requirement of the service, right? Understanding that this is voluntary as well, right? And you build that process, but it might increase the response rates because our response rates are about 10 to 12%, right? And not confident enough to actually make decisions upon what we need to do next. So for us, we're trying to find different ways to see how we can really create opportunities and leverage technologies to collect this information, because it's truly hard.
Thanks. I don't know if Natasha or Maria, you have anything to add on that point?
I think the only thing I would add is that we've been successful at engaging families and youth as advisors who can then tap into their networks. And we also did a survey earlier on in the pandemic to look at, it was just really a point in time survey about who would prefer in-person versus virtual, and some, very high level advantages, disadvantages, like in terms of how people were perceiving the service. And rather than just disseminating it through our own agency, we really used social media and looked at more like a network of providers or a system-wide approach. And that way, we could sort of get a range of perspectives. I know there's some limitations with that because we're not only surveying our own clients, but it gave us a pulse on where people were at in our community and the kinds of gaps that we could potentially address.
I guess I would just add that in this particular survey that we're doing, we're targeting service providers, so the group facilitators, as opposed to direct clients. And so I think we've been lucky just because I think that many of the service providers are really eager to share their thoughts. And so we were surprised to get a good response from our survey. But I think in general, if you can get a 30% response rate or so when you're targeting clients directly, you're doing pretty good. So I think that's pretty standard.
Great, thank you.
We have a question here for Kelly and Daniel. Did you notice any trends in clients who wanted to move strictly towards virtual care going forward?
So the surveys that we collected that focus on client feedback and asked about their preference for virtual versus in-person is an anonymous survey. So we actually aren't able to link it to our clinical data to determine whether there's differences in terms of their presenting problems or symptomatology, demographics, that sort of thing. So yeah, unfortunately, we aren't able to look specifically at preference using the data that we have. In hindsight, I think I wish we had done things differently, but at the time, we were really focusing on just getting feedback in the moment on virtual services so that we could adapt and meet the needs of clients.
We have a question here around the overall context of COVID and how this might influence some of the findings. So I know this was discussed a little bit in terms of that one around self-harm, for example, and this is to any of the presenters who'd like to answer.
I would agree. It's very difficult to disentangle the effects of COVID and the potential benefits or disadvantages of virtual services. Everybody right now, as Mark said, has a lot going on. Our clients, our staff, our caregivers. We hear often in the media that people are under stress and pressure like they've never been before, and so to disentangle that is really a challenge. So I think that really just highlights the importance of continuing to collect data around virtual services after the pandemic is over. And if virtual remains on the menu of options for service delivery, we will definitely have to continue this work just to see how people respond and whether that the effectiveness or the potential for people to benefit in different ways from virtual services differs, outside of the COVID context.
Yeah, I think that's a good point, that perhaps that's kind of future when we're out of this pandemic, we'll be able to assess that a little more readily. Any other comments on this question?
Yeah, just real quickly, I think if you look at the service data, apart from crisis in our inpatient admissions, right, it's, dare I say it, almost business as usual, right? We're not varying differently than our usual service targets. What is different is the degree to which, how significant the clinical presentations are. So for me, I see myself more at tables to where, right, clients are experiencing more significant clinical symptoms and require immediate services, and there's long wait lists for inpatient beds across the province. So I think that that perhaps COVID has exacerbated perhaps or amplified that population and their needs, and couple that with reduced access to provincial inpatient beds, right? It creates a recipe for a crisis, if you will. So for me, once the dust settles, I think it'd be good for us to come back and to really review, right? Almost like a pre and post and an A, B, and A approach, right? To see, right? To even understand the impacts of COVID into our services.
Thanks, Mark. And Natasha, do you have something to add?
Yeah, I would agree. Like it's the saying that's been playing in my mind is necessity is the mother of invention. And so like at this point, we're doing it because we have to, and because I think many of us are also anticipated this great, increase in demand as, things settle down and people sort of are able to deal with the mental health beyond, all of the other basic needs and survival kind of states that many are in right now. But I think that the research that we're doing now is informing, future states. So what does work best in person? What does work well virtually? How can we build on what's working virtually to do more of that? So I think really this is very preliminary, and it's impossible to tease out what's COVID related and not, or maybe not impossible. I'm not a researcher, so perhaps it is, but I would say from my perspective, whatever we're doing now is certainly something that we'll be able to continue to build on to really add that as another opportunity for those seeking services.
Thanks. And just a reminder that we do encourage, if anyone has questions, to type them into the chat, or you can use the raise hand function.
Another question we have here is about Zoom fatigue, and this is something that we talked about in our first webinar, and Mark, you had mentioned in your presentation. But we have a question here from one of the participants saying that you mentioned Zoom fatigue was a challenge for staff, and it's interesting that this didn't come up for the clients. So do you think there's a certain threshold for the amount of time that people can spend, engaging in virtual care, whether they're a provider or a client, before it just becomes too much and the treatment or whichever service they're accessing isn't even effective anymore?
So for me, I think we use Zoom fatigue because we've named it Zoom fatigue, and our clients perhaps use the language, oh, I'm done. I don't want to fill out the survey. I'm out, right? So that's probably their way to offer Zoom fatigue. The other piece, which I found interesting, is our sessions are usually an hour and a half. But some of the data that I haven't shared is our sessions seem to be a little shorter. So about 35 to 40 minutes. And I thought, oh, that's interesting. What's up with that, right? So I got really excited when I saw that, but I don't know what that means, right? So it's only by asking questions. So I think for us, Zoom fatigue, is we understand it because we talk about it, right? We use the name Zoom fatigue, but for clients, it might be in the form of, there's too many distractions. I can't feel like I can focus. Are we done yet? Right? Maybe that's the behavior and language they use. So to answer that question effectively, I don't know if I can, but to combat Zoom fatigue, what we're hoping to do, right, is to ensure that we look at a discipline of practice, and to ensure that when we schedule our meetings, it's super easy, especially for me, right? Back to back to back to back. And then I'm from 8:30 to 5, I have no time, because everything's a priority during these COVID times. So for us, it's to establish a discipline of practice where we get to replenish our cognitive effort bar, I call it, the energy that we do playing video games. Our attention and our focus is something very similar. So we make it a point to develop that discipline of practice to ensure that we break up our time to replenish that focus, so that at our next meeting, I'm my best self. Right, so it's part of safe and effective use of self. Don't know if I answered the question.
No, that's very good, Mark. And I think that's such a good point, is it's a part of that learning process too, right? Like the more you go through that process, the more providers are engaging in virtual care. That's the only way for us to understand sort of what that threshold might be in terms of effectiveness. And it's going to be different for everyone too. And that's part of the, I think, adaptive nature of this whole process and journey of understanding how we deliver virtual care in the best way possible. Thanks, Mark.
Another question we have here is, if you had to roll out virtual services again, what would you do differently? So I guess just reflecting more on that process and lessons learned. And it's for any presenters. It's a big one.
I can just venture. I don't know that we would necessarily do things differently, because we really did try to look at the research and figure out what best practices were. And I think we're all working with very limited information at our fingertips that's very specific to our context. But I think that I perhaps would have started the evaluation process a little bit sooner. I think, just speaking specifically from the project we did, something that was difficult was just engaging youth and families right off the get-go. So, you know, by the time we had sort of were able to recruit them and involve them in the project, we also had started to think about the evaluation framework. And so it really flagged to me the importance of having youth and family engagers on staff or connected to our networks to be able to shift rapidly with us, because there was certainly a gap between, you know, the time that we made a lot of decisions about how we were going to go online and how that was going to look before we could sort of bring them on board to inform what all of that would look like.
Thanks, Natasha. Any other points?
For me, I think having a communication plan, focusing on the communication plan first, right? People had a lot of unanswered questions during a really unpredictable time, unprecedented time. And for us, we were very technical, right? So we said, oh, we got to do this, we got to do this, we got to do this. And then came, oh, we need a communication plan, right? So people were saying, okay, we've got to stop these services for these reasons, but we didn't have that a systematic way to fill in the information black holes until much later. So for me, I think simultaneously in wrestling with the technical pieces of moving bricks and mortar services to a virtual, we would have had a small group that really focused on communicating our work in a systematic way to staff, children, youth, and families, because it was really an anxiety-causing time, right? What do you mean my session is canceled tomorrow? What do you mean I won't see you until a couple of weeks, right? Caused a lot of anxiety to families, and I think we could have done a better job at keeping people, our various stakeholders, up to date with what we needed to do during a really stressful time.
Mm-hmm. Yeah, that makes a lot of sense, Mark, in terms of, you know, you were just going with the motions and kind of implementing what needed to be there, but that the importance of also communicating that to folks along the way.
I just very quickly, I think it's difficult for me to speak to that because I'm from outside of the research perspective, but in hindsight, our team had so much going on when this happened, trying to figure out how we fit in the organization, how we could support frontline staff during the pandemic. We were being pulled in a lot of directions, trying to find ways to, monitor staff who might come down with COVID, and how we then would redeploy staff to those programs, and so developing staff trackers and client trackers, and developing an evaluation plan. So it felt a bit panicked. It felt like just, how do we fit into all of this? And so it's difficult to speak to how we could do things differently, because this was just totally something we had never been through before, and it's really difficult to anticipate, obviously, and what it's going to mean for the agency and for our staff and for our clients. And so we've just kind of done everything we could to support staff and clients as this has unfolded. I think we've in some ways benefited with our evaluation plan, because selfishly, I guess, as the pandemic has sort of dragged on, it's given us more time to think more carefully about how we're going to collect data, how we're going to analyze those data, what that's going to mean for future service delivery, and how we can support that. So yeah, it's a difficult question really to answer. But I think I would like to say I think I'm proud of our team, and I'm proud of how we've been able to support folks as this has happened.
Yeah, and I would echo that. Even through our own virtual care evaluations, everyone was, doing their best and learning along the way and adapting to this unexpected situation.
I think going off on the comment that all of you have made about just how fast everything was moving at the beginning of the pandemic, and having to make adaptations along the way. How were you able to prioritize equity considerations as a part of that? And that's something that we always think about, even before COVID and before the pandemic. But I think when things are happening so fast, it's hard to make those considerations for equity-seeking groups, in addition to making sure that services are just available in general for everyone who needs it. So I'm wondering if any of you can speak to how you either prioritize equity considerations at the beginning or include it as a part of your process.
I'll not being an expert, and I think it's process dictates function, right? So if you have good processes, then usually it contributes to an effective function. So for us, it's ensuring that equity is part of the conversation, the discussion, the planning, and you do so by engaging, right? So Kelly had mentioned surge planning. Holy geez, surge planning. The minute we fell on the plan, it changed, and it changes, and it changes, and it grows, and involves more people. So for us, it was truly engaging partners for us. So it's engaging not only in child and youth, grassroots, multicultural center, other groups, right? It was also ensuring that we brought information regarding what we could contribute. So for example, surge planning, what can we do to help out the different agencies, the smaller agencies, the more diverse agencies during this surge, right? What happens if their needs increase, and what can we do about it? And I think for us, there's a lot of room for improvement, but for us, I think it was through engagement and ensuring that voices were heard, and really offering the opportunity for people to speak. Because what happens, right? We're an itty-bitty agency, and I'm sitting beside our hospital, which has a $500 million budget, which is probably small compared to our sub-Ontario partners. But again, what voice do I have? And never mind the smaller agencies or grassroots agencies. So for me, it's ensuring that everybody has a voice and a space to discuss their contribution, but also what their needs are, and how we collectively as a community can address those needs.
So in terms of our project, because our focus was really on the evaluation of existing virtual groups, down the line, our hope is to be able to better identify gaps and co-create groups together. But right now we're just looking at the transition and impact of those virtual groups. But as a community in Ottawa, we've been very much aware of, the disproportionate impact to marginalized and racialized groups. And so we've come together to develop by the community for the community walk-in services, which are now all housed on one website, which is called Counseling Connect. So I would say that there's been a lot of effort to recognize that there's no one agency who can do this alone, but that if we could buy into this digital health platform and co-deliver services together, that we were much better positioned to meet the needs of the community. And so the three specialty services that exist on that portal are services specific to Indigenous people, specific to the African Black Caribbean community, and to LGBTQ 2S+ communities. And so this is also a pandemic response innovation that's a little bit separate to the work we're doing on groups, but certainly there's so much opportunity for alignment when we look at using groups as that, you know, immediate low threshold access point for people who require help right now.
Do you have a comment, Kelly?
Just to echo Mark and Natasha, just doing our very best to include equity and diversity issues in our conversations, engaging youth and their families in decisions about service delivery, identifying gaps, who are we serving, who are we not serving, how can we do a better job collecting data so that we can identify underserved and underrepresented communities in our region, and then use that to inform outreach activities.
So I'll do one last question, as we're about 12:21 right now. So again, kind of directed towards everyone, as I know we're in these early phases of evaluation. Has anyone started within their organizations to implement some of the pieces that you're finding from the evaluation? So use some of the findings towards making some changes, or is it too early to do that?
Just really short, I think we're in a constant cycle of plan, do, check, act. So we're constantly shifting as, you know, more information becomes available, but we're still in such early days with our evaluation on virtual groups that I would say that we'll probably be implementing much more as those become available.
So for me, I guess I really love your comment, Natasha, because that's exactly what it is, right? It's a cycle. And as we come across some information that we can hang our hat on, then we are able to make a decision, right? And sometimes we get information that leads to more questions, right? So for us, it's almost like as we get more information, there's a bifurcation, right? There's a, oh, but let's ask this question, or, yep, I think we can do this, right? In true evidence-informed decision-making process. And also, we need to incorporate evidence-based practice as well. There's some really great literature and research out there that we need to add to our practice-based evidence, which is, I like practice-based evidence, right? Because I can have evidence-based practice, but try to apply it in Sudbury might look different, and that's the practice-based evidence. And when you add the two pieces, they then lead to a truly evidence-informed practice, which considers both aspects. So for me, I think it is a cycle, Natasha. I would agree with you, and that sometimes it leads to more questions than your to-do list getting longer.
Yeah, same in terms of just it being the really early days of the evaluation. We are still, you know, wrapping up reports to share with folks at the agency. So we've been engaged in ongoing cycle, like plan, do, study, act cycles around reopening our in-person services, and some of that has been used to inform future reopenings and prioritizing clients for service, but or for in-person service, sorry. And so, but in terms of, you know, virtual services and ongoing decisions about the future of virtual services, it's still very early for us.
Well, thank you all for sharing with us today. We really appreciated hearing the different perspectives that folks are taking in terms of evaluating your virtual services. I'm sure this is going to continue to be a hot topic and one that we continue to discuss and learn from. And just wanted to share a quick reminder with all of our participants today that you'll get a link to complete a brief evaluation, and we ask that you do that just to inform our future webinars. But thank you everyone so much for attending today, and this will be archived.